Good morning, everyone. Let us see the module of the throat examination, which includes the history taking, examination of throat, lymph node examination, case discussions, and the instruments. So the throat is divided into oral cavity, oropharynx, and then the larynx. Starting with the oral cavity, which extends from the lips to the anterior tonsillar pillars, including the lips, the teeth, gums, hard palate, buccal mucosa, anterior two-thirds of the tongue, the floor of the mouth, as well as the triangular fossa behind the last lower molar tooth called retromolar trigone, as well as the two sulcus called gingivo-buccal sulcus and the gingivo, the labial sulcus. Coming to the symptoms of oral cavity, which includes the pain, which can be localized due to the caries teeth or the lesions over the tongue or the buccal mucosa, or it could be referred pain to the ears via the fifth cranial nerve, that's a trigeminal nerve. Secondly, there are lesions of oral cavity, which includes mainly the ulcers, can be due to infections, viral or bacterial, immune disorders, trauma, neoplasms, skin disorders, blood disorders, drug allergies, vitamin deficiencies, and the miscellaneous conditions like cancer chemotherapy and the radiation mucositis. There can also be an abnormal growth due to benign or the malignant lesions. So other symptoms include the trismus, which is difficulty in opening the mouth, can be due to ulcerative lesions, as well as the oral submucosal fibrosis. There can be disturbance of taste commonly due to coated tongue, or can be due to injury to the chorda tympani nerve. So there can be disturbance of salivation, which is an excessive salivation, or a dryness of the mouth called xerostomia, which is due to the mouth breathing seen in the adenoid hypertrophy, or can be due to poor orodental hygiene. Then we have the oropharynx, which lies against the oral cavity, starting from the anterior tonsillar pillars made up of palatoglossal arch, then the posterior tonsillar pillars corresponding to palatopharyngeal arch. Between these, we have the tonsils, which are ovoid mass of lymphoid tissue, also called the palatine tonsils. Oropharynx is bounded above by the junction of hard palate and the soft palate, and below by the V-shaped row of circumvallate papillae. Coming to the symptoms of oropharynx includes the sore throat, which is one of the most commonest symptom of the throat, and that can be due to acute or chronic tonsillitis, pharyngitis. There can be dysphagia, difficulty swallowing, odynophagia, which is painful swallowing, or change in the voice due to the paralysis of soft palate or the space occupying lesions of the oropharynx, which gives the hot potato voice or a muffled voice. Snoring or the sleep apnea can be seen whenever there is an obstruction due to the large tonsils or adenoid hypertrophy. Halitosis, which is a bad breath due to the infected tonsils or ulcerative lesions, or sometimes the malignancies. And earache, which is the referred pain in the ear, that is due to the glossopharyngeal nerve or the ninth cranial nerve. And there can be an abnormal growth, which are the benign and malignant lesions of oropharynx, but sometimes the enlarged circumvallate papillae can present with the fear of cancer, and that has to be ruled out. Now let us see the examination of oral cavity and the oropharynx, which is done with the help of bull's eye lamp and the concave head mirror, which is used to focus the light, and the tongue depressor called lax tongue depressor. Firstly, examine the lips, upper lip and the lower lip for any fissures, for any vesicles, scars. Buccal mucosa is now examined by retracting the cheeks with the help of tongue depressor bilaterally. And also look for opening of the parotid duct against the upper second molar tooth. Teeth and gums are examined. Retromolar trigone is examined. Now the floor of the mouth is examined for the openings of submandibular duct on either side of the frenulum. The size of the frenulum is seen and any mass or lesion should be examined. Now the anterior 2/3 of the tongue is examined. Movements of the tongue and hard palate is examined. Now the anterior 2/3 of the tongue is depressed with the flat end of tongue depressor to look for oropharynx, and the posterior 1/3 should not be touched to prevent the gag reflex. Now, the lateral gutters are examined for any mass or lesions with the help of the two tongue depressors, one to retract the cheek and other to retract the tongue. And any mass in the floor of the mouth should be examined by bimanual palpation to differentiate it from submandibular salivary gland swellings from that of the submandibular lymph nodes. Next, we have the larynx, which consists of the three paired as well as three unpaired cartilages. Anteriorly, we can look at the epiglottis, thyroid cartilage, cricoid cartilage. Then posteriorly, we can make out the leaf-like structure of epiglottis, then arytenoid cartilages, which are paired cartilages. Then on a sagittal section, we can also see the true as well as the false occult cords. So the symptoms of larynx include the voice disorders, mainly the hoarseness of the voice or the puberphonia, cough and expectorations, repeated clearing of the throat, the pain in the throat, mass in the neck, or the respiratory obstructions. The larynx is examined by either indirect laryngoscopy as well as the rigid endoscopy. Starting with the indirect laryngoscopy, the patient is made to sit erect in front of the examiner, leaning slightly towards the examiner. The tongue is protruded out and it is held firmly with a gauze piece with the thumb and the middle finger. An index finger is used to keep the upper lip and the moustache away from the way. Now the laryngeal mirror of size 4 to 6 is held against the uvula and soft palate, which is warmed and tested against the back of the hand. And patient is asked to say A or E to look for adduction as well as the tension of the vocal cords. The structure that's seen on indirect laryngoscopy are the base of the tongue, the median glossoepiglottic fold, as well as the epiglottis, then valvuculae, then the vocal cords, the true and the false vocal cords, arytenoids on either side, aryepiglottic folds, then the pyriform sinuses. Nextly, we have the rigid endoscopy, which gives the magnified view of the larynx, where the fiber optic laryngoscope is passed behind the uvula and the structures are examined. The patient is asked to say A or E to look for movements of the cords. Here, the vocal cords adduction as well as abduction can be seen. The epiglottis can be seen. Pyriform fossa on either side can be seen. Then we have the lymph node examination, which is an important aspect of the larynx examination, where the neck nodes are classified into the three groups: upper horizontal chain, anterior cervical and lateral cervical group, and also classified into 7 important levels. Level 1 divided into 1A and 1B corresponding to submental and submandibular lymph nodes respectively. 2, 3, 4 corresponds to upper jugular, middle jugular, lower jugular respectively. Then we have 5, which includes the posterior triangular groups divided into 5A, 5B, corresponding to spinal accessory group as well as the transverse cervical groups respectively. Then we have 6, including the pre-laryngeal, pretracheal and paratracheal lymph nodes. Then the level 7 corresponding to mediastinal lymph nodes. These neck nodes are better palpated while standing at the back of the patient with the neck slightly flexed to achieve the relaxation of the muscles, and the nodes are examined in the following order of upper horizontal chain, that includes the submental, submandibular, parotid, facial, postauricular and occipital nodes. Then the external jugular chain, which lies superficial to sternocleidomastoid muscle. Secondly, the internal jugular chain that includes the upper, middle and the lower jugular group of lymph nodes. Then the spinal accessory chain, the transverse cervical chain, anterior jugular chain. Then the juxtavisceral chain, which includes the pre-laryngeal, pretracheal and the paratracheal lymph nodes. And whenever a lymph node is examined, we should always look for the location of the nodes, the number of nodes, the size of the nodes, consistency of the nodes, the tenderness of the nodes as well as the fixity to the overlying skin. Next, we have the case scenario where a 27 years female presented with a recurrent throat pain since 2 years with halitosis, difficulty swallowing. On examination reveals the enlargement of bilateral tonsils, hyperemia of anterior pillars and palpable jugulodigastric lymph nodes bilaterally. So here the most probable diagnosis would be the chronic tonsillitis, and the features suggestive are: one is the age as well as the duration, that is since 2 years, and the enlargement of the bilateral tonsils and hyperemia of anterior pillars alone, as well as the palpable lymph nodes. This chronic tonsillitis can be a complication of acute tonsillitis, or it could be due to chronic sinusitis or the dental infections, and tonsils are enlarged in varying degrees. But in the case of fibroid type, the tonsils are small and infected, and pressure on the anterior pillar expresses the frank pus or the cheesy material demonstrated by the Irwin-Moore sign. So we have 3 types of it: chronic parenchymatous tonsillitis, where the tonsils are uniformly enlarged; then follicular tonsillitis, where the follicles are seen over the crypts of the tonsils as yellow spots; then we have fibroid tonsillitis, where the tonsils are small and fibroid. So looking into grades of hypertrophy, we have 0, which is the post-tonsillectomy status, 1+, where the tonsil are present within the tonsillar fossa, then 2+, where the tonsils occupy about 50% of the lateral dimensions of oropharynx, 3+, where the posterior pillars are not seen and they occupy 75% of lateral dimension of oropharynx, then the 4+, where the tonsils come into the midline, both touch each other, also called the kissing tonsils. Now, how is it treated? Firstly, the conservative management with the hydration with a plenty of fluids. Secondly, the analgesics to reduce the pain. Next, we have to give the antibiotics to control the infections, where the penicillin groups are the drug of choice, as the streptococcus is the main causative agent along with the beta-lactamase inhibitors. Then the tonsillectomy is indicated in case of the recurrent infections of the throat and any obstructions due to the enlarged tonsils causing the obstructive sleep apnea as well as a respiratory difficulty, as well as in the case of the malignancy. Now the complications of chronic tonsillitis are the tonsilloliths, which are nothing but the calculus of tonsils, tonsillar cysts, intratonsillar abscess, peritonsillar abscess, parapharyngeal abscess, otitis media and cervical abscess, whereas the rheumatic fever and subacute bacterial endocarditis are mainly due to the acute tonsillitis. Then we have the aphthous ulcers, which are the most common ulcerative lesions seen in the OPD. And these ulcers are recurrent and superficial ulcers, usually involving the movable mucosa, that is the inner surface of the lips, buccal mucosa, tongue, floor of the mouth, soft palate, usually sparing the hard palate and gingival mucosa. So etiology is not known, but possibly could be an autoimmune process, nutritional deficiencies, viral and bacterial infections, the food allergies, hormonal changes, or sometimes due to stress. And these ulcers are painful and multiple ulcers which have sloughy base with marked hyperemia around the margin of the ulcer, and they usually heal within 7 to 10 days. Lastly, let us look into some of the instruments used in the examination of throat. The lax tongue depressor, which is a flat end and a slightly curved end, where the flat end is mainly used to examine the oral cavity and oropharynx by depressing the anterior two-thirds of the tongue and never the posterior one-third to prevent the gag reflex. It is also used in the cold spatula test to check the patency of nasal passage. Then we have the indirect laryngoscopy mirror, which is mainly used to examine the base of the tongue, valvular, epiglottic folds, ventricular bands, vocal cords, piriform fossa, and interadenoid region to look for any foreign bodies or inflammatory and non-inflammatory conditions. And it has to be held like a pen and should be warmed over the spirit lamp and tested against the back of the hand to prevent fogging before insertion into the mouth. And the handle is straight, unlike the posterior rhinoscopy mirror, which is angulated. Coming to the tonsillectomy instruments, we have the Boyle-Davis mouth gag with the tongue blade, which is used to keep the mouth open during the surgeries of tonsillectomy, adenoidectomy, surgeries of palate and the nasopharynx, where the different size of tongue blades can be used. Then we have the Jaffin bipods, which is mainly used to fix the Boyle-Davis mouth gag for the numerous surgeries, including the adenotonsillectomy. Then we have the Dennis Brown tonsil holding forceps, which is used to hold the tonsils and pull it medially during the process of dissection, and the edges of the jaw are blunt and do not cut the tissue. Then we have the Eve tonsillar snare, where the snare has a stainless steel, which is usually 3 inches long with a thickness of 28 gauge, and that is used to snare the lower pole of the tonsil after dissection. Then we have Mollison's tonsillar blunt dissector and the anterior pillar retractor, which has a blunt end used for the non-traumatic dissection of the tonsil, where the retracting end is mainly used to retract the anterior pillar to look for any bleeding points. Then we have the Burkett straight first artery forceps, which is used to catch the bleeding points in the tonsillar fossa after tonsillectomy. Then we have the Walk tenaculum forceps, which is a single-toothed forceps used in tonsillectomy to incise the anterior pillar or for the dissection of tonsil from its bed, and also as a swab holder. Lastly, we have the St. Clair Thompson's adenoid curette with cage, which is used to curette the adenoids by the blind technique. It is held like a dagger, and the cage is used to prevent the slipping of the excised tissue into the throat. Thank you.